Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Before we get started on our fifth and final episode of this series with Dr. Grummons, I want to make sure you have all subscribed to my channel on YouTube, Airway Answers with Nicole Goldfarb, to help keep this going, and give us some likes, some thumbs up, some comments to show your love for Dr. Grummons, who has spent so much of his time helping to teach all of us. I'm going to start out reviewing his bio one more time in case anybody has not tuned into the first 4 episodes in this series. So you can listen to this special part 5, which is a question and answer with me and Dr. Grummons. So we'll start out with his bio and then we'll get into the episode. Dr. Grummons is a board-certified orthodontist and professor at the Loma Linda University Medical Center Orthodontic Department for 35 years. Dr. Grummons is a leader in pediatric and adolescent airway development approaches with earlier craniofacial orthopedic interventions for breathing, airway, structural problems with life-changing benefits. His facial frontal analysis and face mask orthopedic appliance innovations are extensively utilized. Dr. Grummons developed productive practices in both Marina del Rey and Spokane, Washington. He has appeared before orthodontic and worldwide airway conferences and has published a textbook and many journal articles. He has made radio and TV appearances and provides clinical with practice success and coaching. And he has authored and lectured for over 35 years in 45 states around the United States, and done CEs for 23 orthodontic departments, lectured in 9 foreign countries and 4 continents. So thank you so much for all of your expertise. And we really look forward to all the information that you've disclosed to us.
Now let's do this.
Welcome back, everybody.
There's a lot we didn't cover. Really, I wanted to remark that we didn't cover remote monitoring very deeply, just commented. We didn't do rhinometry. All the use of AI, especially productivity, Grok 3, stuff like that, brain mapping, inflammation management clinically, what all we need to do, TMD, TMJ comorbidities, some of that stuff, workflow, and then a little bit how to build a lab within your practice. So there's an imaging center, and then the profits from that, we have to be careful about Stark laws and sunshine laws, but that can be, actually, we directed it toward the kids' education funds. So all that time, there was a percentage that was going in those funds. So it's kind of an idea for doctors and colleagues who are doing that. We didn't cover HRV, the heart rate variability aspects of these things. Goodness, thriving, social media, radiation truth, craniofacial. My gosh, there's a lot more to talk about.
There's so much to learn in this airway world, but we're going to do like multiple. Let's do 20 parts to this. There's so much. No, but I think this is great. What we've covered, all of the orthodontic piece. You went over so much in those first parts. And what I want today is to be able to do a question and answer and go over some questions that I have. Hopefully everybody listened to the first part so they got all the details. And that was basically a course. That was a course that you just gave. So much information. So let's go over some questions that I have related to what you talked about. First, I did want to know, were you always practicing with airway-friendly techniques, or how did that change throughout your career as an orthodontist?
Well, the answer would be no. None of us started out really knowing these things foundationally. In our training, one thing that I had no idea would play in, my research was on mandibular setback surgeries and the effect on airway and facial aesthetics. And TMJ was part of that. But I had no idea that stuff we were measuring in the 70s in that thesis work would somehow be a little bit of a inspiration to me to look deeper, because I saw something in those patients that wasn't favorable. And so when I got into practice and we started doing the orthodontic surgery so much, we really looked to midface. So what can we do to advance the midface and then bring the mandible with it if it was needed? But rarely would we set the lower back, or if we did, minimally, so that we just had better aesthetics. And then in the 80s, I had tomography and we had cine fluoroscopy. We had different things we were doing. We had ENT support. So I had the benefits of Dr. Grassan, Dr. Reem, a couple of local ENT people in Marina del Rey that were on board. So they taught me a lot. A gentleman named George Meredith from the Midwest as an ENT that would fly out to the office because he wanted to see what we were doing in ortho, which was unusual for an ENT to be coming to the office. But I learned so much from him. He evaluated every one of our kids, which drove me deeper with interest. So that was in the 80s. And then we had speech, SLP on staff. So Debbie was on staff with us for 12 years, and that taught us even more. So in the 80s, that really developed. Then cone beam came, of course, and that was when anatomic truths were obvious. And so early 2000s, we were early adopters, and that's really when it hit the sky. The skies opened up and we learned.
Do you think it's important for every orthodontist and dentist to have cone beam in their office or to be utilizing CBCT imaging?
I think the utilization is an absolute yes. I mean, there's just so much we can't see and understand. It is expensive. In a workflow explanation, I would explain that we had one unit, but at one time we had 3 offices, and everybody would come to the central home office for imaging. And I cross-trained 3 people. So it isn't like you have one tech that can do it all. We cross-trained 3. So we were always able to handle unexpected scheduling or anything that came up, or if somebody was out for a day, we were always covered. So I had it early on when it was almost 3 times as expensive as today. It was $260,000, the first unit I put in. And that was in the early, like 2004, 2005 and through there. And then of course it came down. The software that I went with was the Dolphin and the Anatomage. We just loved what it could do besides in vivo. So that made a difference for my learning also. And it also made it interesting to colleagues, because many of my colleagues would ask, would we take a scan for them? Because they didn't have it, but they knew they needed the information. So they would send patients. So we did many of those for no charge. And the ENT people started sending to us also for scans. So that basically says these things are interesting, they're important, they're revealing. It's standard practice. It should be.
That's good to know. And what are your thoughts when looking at Airway on the CBCT? Some people maybe over rely on that, like total airway volume, or people use different postures, and they're trying to come up with a normative posture because the way the head is positioned can impact that total airway reading or the minimal point. So how would you advise, or what are your thoughts on using that CBC to look at airway volume and area of restriction?
Well, I'm interested in it, but it's not the key thing. I'm going to first of all scroll through the anatomy, and I go axial all the way up and through, and then coronal all the way through the volume. And then we come back and do sagittal. I think most people are probably curious from the sagittal because that's our training in cephalometrics, but that's actually the third scroll going through. And we're looking for pathosis, creating our report, but I'm looking at cross-sectional area and restriction and that sort of thing, but I'm looking more at the anatomy and the incidental findings, and then any pathosis that we find. And then I'm making screenshots all the way through. And we rotate the volume, we tip the volume up, we look at all different angles to get a different viewpoint, not just the 3 scrolls through. We find many more interesting things when we rotate the volume and then capture that. So we might have 30 or 40 renderings that we create just by going through the first viewing and scrolling. So I think we have to have it. And colleagues that don't have it probably don't know what they don't know. And it's just necessary. I couldn't operate without it.
Okay, that's really good to know. What about DICE, drug-induced sleep endoscopy, in the diagnostic process or helping with your orthodontic plan? Is that helpful or not necessary, because you can gather the information you need from your exam and from the CBCT to know what you have to treat orthodontically?
Well, I can gather enough, but I think DICE is important in some of the specific cases. Like a colleague, Mark Cruz, is doing such a good job of this and relies on that much more than maybe some of us. I do take different views, like a rest position. I want to see where the tongue is postured, that sort of thing. But I rely more on my clinical exam than anything. In a deep screening questionnaire, the video of sleep, and I'm going to reach for something. Everybody should have a speculum. I just think everybody in orthodontic practice and practice should look up the nose. We take pictures up the nose, the inflammation, the turbinate regions, the mucositis, the rhinitis, whatever names we want to put on it. But there's boggy mucosa and it's inflamed. And we need to understand that and record that, but also impress upon the family the need to do something about that. So speculum, they're as inexpensive as $10 or so. And so I think we need to have that and use it. But back to the point, I do rely on the PES. If somebody's having a sleep study, then things that Dr. Jerry Simmons has taught us about the importance of the esophageal exam, I think that's really an important factor out of my range, obviously, but I'm going to refer and ask that the patient get a better sleep study than just HST or something like that. And so that is a level up that most of us probably don't know about or aren't using that I think really should be utilized more. But I want to rely on my imaging, my good exam. And if I don't know, I'm going to rely on my colleagues too. I mean, this is a team effort.
Yeah. And that's what differentiates an airway educated orthodontist versus maybe a more traditional orthodontist who's just concerned about cosmetics or lining up teeth, is the fact that you just brought out a speculum. You just talked about the nose, looking in the nose. How many people go to the orthodontic appointment and the orthodontist looks in the nose, right? I mean, that's really important. In the first part of your lectures, part 1, you talked all about things that probably a lot of orthodontists never think about. Nasal hygiene, you
Yes.
know, that's a huge thing
Yep.
to think about, right? And nitric oxide. And it's
Yes.
just important that you pay attention to that piece, and that really separates what an airway minded orthodontist might be thinking of whole body, nose breathing. How is the airway going to collapse when there's turbulence in the airflow, and how can we open things up? So that's really a beautiful thought. I
Well,
don't think I've orthodontist bring out a speculum before.
yeah, well, it's I can't operate without it. But the George Meredith, this ENT friend back in the early 80s, he brought one, gave it to me. He said, "You need to be using this." He was right. I never operated without it. So, and another thing that is similar in the exam, like if we have a craniocervical problem or findings, and we're going to ask permission to palpate muscles of the upper quarter, the neck, shoulder, I always ask permission first, just like with the speculum. Here's what I'm interested in knowing and explain a little bit. May I have permission to do this? Because it is unusual. And I don't want the mom thinking this guy's really weird. I want this mom to think this guy's really thorough.
It's so true. It's probably more on the rare side, but more common with our group of people for orthodontists to be looking at muscles and different parts versus just teeth, and so it's probably could be confusing for a parent or a new patient to think my orthodontist is looking up my nose, they're palpating my neck muscles, but that's what it's all about. The body is interconnected. We
Yeah.
can't ignore other parts and just focus on tooth alignment. Now we know.
Well, there's a transformation that I sense in the course of that exam. After a little bit of that, whether they've had another opinion or not, usually they start to become impressed. It's like they're curious, and I'm explaining it as I talk a lot as I'm doing the exam. What am I seeing, and what's the importance of that? Great moment for education and communication and building trust. But I do that, and I can sense when the trust is starting to happen and the curiosity is happening, but they become at ease, but they become impressed because we want our child or myself well taken care of. So when I bring the stethoscope out, it's the same thing. I'm listening to the joint because there's things we can feel, palpate, and not hear, but things we can hear and not palpate. So there's certain movements and disc relocation and crepitus and different conditions within the joint that I can hear, but not necessarily palpate well. So I'm doing that, but the patient, whoever's escorting the patient or the adult patient themselves they're going to be sensing that something more thorough is happening here. And I'd rather be the last office in a series of opinions because I think we're going to win them over. And not that it's a contest. It's a matter of doing the right thing, the best thing we can for each patient.
Yeah. And that's interesting. So you said you use a stethoscope to listen to the joint, the speculum looking up the nose. Any other tools that might not be standard in orthodontic practice that you might use or recommend?
Well, we use different muscle stim and that sort of thing, but not in the exam necessarily. But
Okay.
sometimes we might use something as simple as one of the muscle guns on neck and shoulder, just to say, this is something you can get and use at home. Let's get you over to physical therapy, OT, something like that to guide you, because it's not just buy something, use it. Let's have some supervision and, the professional. But it starts to make the point that how you function, how the craniocervical complex functions has everything to do with how the mandible functions, the nasal respiratory complex. So all this stuff we're trying to help I'll do my part, but I want the other teammates to do their part for your sake, for your benefit. And they may choose away from it, but I want to at least bring it up on the menu.
Yeah, definitely. It's definitely a team effort. Not one of us could tackle all of these issues that are really multifactorial when we're talking about the human body, the craniofacial respiratory complex. There's all different components that we all need to work together to address for the health benefits of our patients.
Two more
Yeah.
things I didn't mention so far. Another couple of tools is a 2x2 gauze, because you can't just open the mouth, say, ah. I want a 2x2 gauze to gently grip the tongue, roll the tongue over, because basically, different cancers, squamous, that sort of thing are at the base of the tongue, other findings. So I have to have the tongue extend and roll so I can visualize these areas. I'm going to palpate the floor of the mouth, and I'm going to also just simply use a tongue blade so that when they say, I'm using the tongue blade to actually displace the dorsum so I can really view the pharynx better. And so when I'm recording, say, the malum patti or something like that, I want to actually visualize as much as I can around the pharyngeal region.
What about referring for sleep studies or the importance of sleep studies for children and adults? How does that play into your role as an orthodontist? You
I,
feel that you need to refer children for sleep studies often, or it doesn't necessarily change your technique or your treatment plan?
well, I do think we need to refer. And in fact, a lot of us are feeling incomplete by the AO white paper from 2020, the recent conference and stuff. And we want to do more, and they're challenging us to do more, but we are doing those things, and not routinely. We might start with an HST on a kid to get some idea of what might be the problem. And then from there, the pulmonologist, the ENT are going to participate. We have trouble going through the primary care person. They usually don't understand. Usually it's a barrier. Usually it's a dead end for us, or at least a roadblock. And so I'll directly refer usually to pulmonology and pediatric if there's one in the community. And I first have built a relationship with them. I've sent some imaging and our findings, the history, the video from sleep, those things, to lay some groundwork. And usually they're impressed by that because they haven't received it before, and they probably don't do it themselves. And so it really builds a relationship quickly. But I do refer for those.
And then how do you handle cases where maybe you've looked in the nose and you see the malocclusion, you see the airway problems, the child has gotten a sleep study and it comes back mild or just snoring and there's no recommendation? How do you handle that with the parents and the patient to keep them on board with your orthodontic plan?
Well, making sure there's not some neurologic reason or central CNS reason, those things are important to have out of the picture. But once we've swept away those things, then we're probably going to go into some kind of therapy, some kind of appliances, and get something started. If there's ENT concern, that's a priority. I always tell them we've got to get the nose box working, because you got two major parts of this airway, the nose and the mouth. And we'll do the mouth and the jaws and all the things that are related to that. But we need to help to get that nose box working. And so then the inflammatory conditions, the TNA, the scan's going to tell us about the sinuses, because we think TNA, but gosh, the sinuses are hugely important and understanding. So we want to have that stuff treated, managed, and then we become the priority. So we have to be second or third. Speech people, they're hugely important, but I have to first change the environment so my myofunctional person can have a better situation to work with and can have success. So I need to usually set that up, and then I would have already mentioned the importance of myofunctional, but we might time it to be 3 months, 6 months in. We're going to now bring that person on the team, because those are issues that are very important too. But I don't know if I've answered the question, but we don't do a sleep study on everybody for sure.
And what about, do you give parents a warning or heads up if they're going to get a sleep study that the results might come back mild, but it doesn't mean we don't treat? It doesn't mean there's not a problem. Do you have to give a warning ever to parents?
I do. I do that as a matter of patient management, but also I think it helps them know that I understand a little bit deeper about what could be the report or what could be the opinion that comes back. So it's not like they're right and we're wrong or the opposite. It's that this is kind of how things tend to be. And it's difficult with children, newer territory. So sometimes the colleague isn't quite up to speed with what we're doing. Maybe they've looked online and they think this is OSA, it's an old person problem. That why do kids have sleep studies and these things done. So it takes a lot of education there. Quite honestly, there's a lot of times they don't do it yet. They want to think about it type thing. And yet we've got to intervene. There are things that need attention to get this kid sleeping, thriving, and so on, breathing better, all that. So in a lot of cases, certainly probably 2 out of 3, there may be a delay, could be insurance reasons. It might be the 2 or 3 times dealing with that, which might eat up some months. So I don't want to wait months to help the child. So we'll intervene.
Yeah, letting the parent know the importance of intervening in all capacities. And I really liked how you said, you mentioned the other fields, the other specialties, the other areas that need to be treated. So even though you're an orthodontist and you're focused on the cranioskeletal complex, you're also talking about muscular components. So you're mentioning to them about myofunctional therapy. You're
Yes.
mentioning to the parent about ENT, allergy, nose breathing. You're bringing in these other components. So it's not surprising or as overwhelming to them. They realize there's a holistic nature to this treatment process. And that's important.
And then quickly too, we're bringing in the dietary aspect, the
Or-
environmental stuff. And then what do we do for supplementation, or how do you get your nutrients? And so some parents are more interested than others, but we bring up the various things they can be doing for immune support. And what can they be doing to help with wellness? And sometimes it's a cost factor where someone goes, man, those things are expensive. And they are sometimes, but yet we want to bring that up, and simple things like curcumin or some kind of supplements that could be in there, wellness support. We do that.
Well, although it's overwhelming because there's a lot of factors, I feel like it's less confusing if all of us different practitioners, all of us specialists are saying the same things. We're talking about the same areas. The nose breathing, the health, tackling allergies, to all the different components, even though we're not treating all those components,
Right.
if we're all discussing it, it's less confusing for parents versus maybe just the myofunctional therapist is just talking about muscles, and just the orthodontist is just talking about teeth, and just the ENT is just talking about nose breathing. But if we're all mentioning our different aspects as part of the puzzle and part of the big picture, I feel like it makes it a little more black and white and less confusing for patients and parents, right? They realize we're all on the same page. So I think that's really nice how you do bring up all those different aspects when you're treating orthodontically. And you created the Grummons protraction face mask. So I have questions about this. Should we
Okay.
move on to the mask?
Sure, let's do it. I like that one.
Okay, so we talked about how it's attached. Well, can you actually just talk about where it's affixed on the face and why you feel that's more beneficial than maybe having chin cup or other components? I know you went over this in the prior lectures, but just like a quick summary.
Sure. Well, actually, the ones that are on forehead and chin are very beneficial also. It's just that compression on the jaw then translates to compression at the posterior attachment within the joints. That's not a load-bearing zone. And so the posterior attachment, if it's compressed for 6, 8, 10 hours while the child wears this, knowing that there's heavy elastic traction to produce the protraction, that's quite a load that's sustained. And our jaw is meant to be moving, not just in a sustained load. So it's compressive loading and it's sustained and it's for hours. And so it affects the vascularity, it affects all the nutrient exchange. So over time, Matani in Japan is one of the many that published well, but about 24% of the patients that he followed that had chin cup loading had an internal derangement at maturity. That caught my attention. That was in the late 80s. And that's when I had the prototype of this, and then finally the design. So it caught my attention because it supported getting off the chin if we could. And then the design didn't change much, but what did change is just using some things to help. I have here a package that I just got to prepare for today, but it's just some of the makeup sponges, and there's different shapes and thicknesses, but they're so helpful to put under this for comfort. And another thing that's important in it is just starting with 1 hour a night, and then maybe second week, 2 hours a night. So the patient gradually, like an exercise, gets used to it. And then you increase what you're doing and the load, but just gradually, starting with light elastics and then moving up to heavier elastics for the traction benefit. And then taking it off intervals. If the child is uncomfortable for 2 or 3 nights, just leave it off and wear it a couple hours in the evening, just kind of get back where things are comfortable again. So being reasonable with what we're trying to do. But if somebody is using the chin load, I'm not going to be critical of that. I just have had patients come in who might have transferred in they were on face mask, or they've come from another office where things weren't working out. And as soon as we put them on this mask, they go, oh, that's so much more comfortable. And in fact, during one of the sessions, I showed a video of a teenage girl who had just transferred in, and we switched the mask. And that was her comment, because it is uncomfortable. If we just take on say on a desk, we put our hand on our fist on our chin and lean into it and go ahead and bite and hold it. It doesn't take but seconds. We start sensing that's not normal. It doesn't feel comfortable. Right. So those things were on my mind. And being a TMJ guy and all that for a lot of years probably had more impression upon me to consider that. So that's.
And so the Grummons protection face mask, what do you call the part that's on the zygoma? The
malar support. Okay. Malar. This is zygoma. Yeah.
So does that impact mid-face development, the pressure there?
That's the misunderstood part. Yes, it does. And so we don't use it on a 1 or 2 or 3-year-old because of that factor. It's more important to not have compression in that area as it matures. But I showed you the Dallaire and the Petit research and all that. And I showed you the histology, the resting lines, and how well this part of the face is put together into the inferior and lateral wall of the orbit. This is an area that's not intended to move. I mean, we're not going to have pressure there and displace the orbit somehow. So it's inappropriate to do it before age 2 or 3. I stay off it for those reasons. And typically in a mid-face deficiency, the malar process is underdeveloped. So sometimes colleagues will see me using this on an 8 or 10-year-old, and the malar is not fully developed like we'd like to see, but it's not because of the mask. That would have been insufficient growth several years before that. It never developed enough. So that is part of the mid-face deficiency.
That's good to know. And I have notes. I'm like looking through all my notes from the last lectures, and you talked about how that zygoma or that suture fuses or develops early.
Yeah, it's not. It's still a resting line, and is a very tortuous suture line. Zygomatical maxillary suture is not just a suture that's somewhat of a line. It's very much switchbacks. So it's highly convoluted. So it's meant to not change. It can take trauma, it can take support, it can take compression.
So after about the age of 2 to 3.
Yeah.
Okay.
That's use this, but prior to that, if you're doing really early stuff, I'd go on the chin, because it's more important to treat the mid-face problem and be less concerned about the joint and the chin and all this other stuff. I want to get to the mid-face. And if a colleague said, you know what, I don't think I'm going to put something there until they're 6 or 8. Okay, get on the mid-face early though. If the child's got a deficiency at 2, 3, 4, begin the process. And if your choice is to use the chin load, I'm okay with it for the sake of the child getting some help.
Okay, that's really great. So after age 2 or 3, the zygomatic maxillary suture is very stable, we're saying. So that pressure is not going to cause much change, if any change.
It's not going to make it go from normal to being deficient flat. That it's insufficient already. And then we're going to, if we need to, we might even put an implant there later on. We're going to try to protract and influence it. And it does influence it some. But because the whole maxillae has a process, there's the zygomatic part that goes up and interdigitates. So there's a major little wing that comes off the maxillae up to the zygoma. So we do want that to come forward, and that does give better support. But that ends kind of in this region. So I mean, go back and look at the anatomy, and then it makes it clear. This part will be stable. This part in front of it, medial to it, and inferior and forward of it, that part we want to develop. Yeah.
Okay. And you covered that in detail in the lecture, and that makes sense. So what about adults who are doing MARPE, and they say now the sutures are more mobile, and I've seen adults using protraction face masks. What are your thoughts on that?
If I had to choose, I would say do one-step surgery correction, because it's for sure. We're in there, we're mobilizing the segments. If it needs to go forward 4 to 6 millimeters, I can't do that with a face mask and a MARPE. I showed 2 cases, but we certainly have used it, but we use it with SARPEs. And so probably my colleagues who are doing it with MARPE will have better success doing the mask, but I don't know what kind of mask they're using, because we would probably want a mask on the chin so we aren't having anything up in these areas, because we're trying to relocate the whole
Yeah,
craniofacial nasal respiratory complex forward.
that's
So
true.
yeah,
That definitely makes sense.
sure. Yeah,
Well, in fact, when I did my MARPE, I had been on a CPAP and I did the MSC technique. And
yeah,
right when I started that, or when the suture split, I stopped using the CPAP because I didn't want any pressure on my face. That was just my own personal decision, because things are loose, things are moving. Let's get as much to mobilize and come forward versus having something push it back. So that was just my own personal recommendation for myself. Nobody told me to
but
stop
you were
wearing this.
completely right, because on the kids, I showed some research on it, but on the kids, we don't want that nasal mask or face mask from an airway standpoint, because it does influence the sutures.
Yeah.
Yeah.
Well, now that leads perfectly into my next question. I'm going to say a bad word, headgear. Remember, you didn't like headgear.
Well,
Okay.
actually, I'm not in the camp that says, "Oh, that's terrible, that's bad," all that. We were trained in it, of course, but
Yeah.
I have to tell you, when we got trained, we were really. It was pounded into us that, are we doing orthopedics with this, or are we doing it for anchorage control and orthodontic management of the case? And most of the time, we're using it to help control where the molars sat, as we're using elastics and doing different methods of level align, all that. Our training wasn't much extraction, so that was favorable as it turned out. But right out of my residency, I took Ricketts courses right away, Gugino and Bench and all the bunch, to learn all the different ways we can develop arch and anchor teeth with quad helix and transpalatal bars and removable appliances and splints and all kinds of sectional mechanics that changed everything. So all of a sudden we didn't need the headgear for that stuff. We had other methods that we could use. So that broke that thinking right away. And I'm sure in the training, some of the instructors at least said, it's class 2, we got to get them on a headgear. So yes, I didn't like that. When I got into practice, I just never did that. And so we were using posture forward appliances early on. And that really is a credit back to two gentlemen named Farah and McCarty that are in Alabama. They've passed away since, but two gentlemen that were going around the circuit in the late 70s teaching TMJ and the importance of posturing the mandible, unlocking the mandible. And we applied that immediately to orthodontics. And then Frankel from Germany and others were already lecturing, Herbst, Pancheras, all these people we were influenced by took us right away from the headgear and took us away from all the extraction stuff. So we weren't retracting, bringing things forward. Unlocking was what it was called.
And yeah, that's great. And that makes perfect sense. That word unlocking. I mean, that's what they say, right? That mandible can be trapped, unlocking, untrapping. So
Yeah.
that's great. You had that early experience. So you went down that pathway of protracting versus retracting. Would you say a headgear or a neck gear is it ever appropriate?
Well, I think I wouldn't criticize a colleague for using it. It's how they use it.
Okay.
If we're using it to be anchorage rather than a quad helix or palatal bar or something that maybe a colleague doesn't like, I know in some international countries, they would tend to use it as anchorage and just nighttime wear. If I have to step back and understand what else is the mechanics, the biomechanics that colleague's using, because just because they have a patient on it, if it's light force for holding placement of teeth and not orthopedics, then they're really not retracting the face. But if they're extracting and bringing the teeth back as part of it, then that's a whole different story, different answer. But if it's simply to assist in rotating upper molars or doing something that's better done by in the mouth appliances rather than headgear, then I understand why that colleague's using it. But most colleagues aren't doing it that way today. They know better. There's so many other alternatives. I mean, even with the aligners, we can derotate molars beautifully. So there's
Okay.
things we can do today that we used to rely on those appliances for. But
Okay, that's good to know. That's another perspective, that it's not always what we think it's being used for. There's other
heavy
reasons why.
force is orthopedics, and none of us, we just don't do orthopedics there. We're pretty much wanting that unlocking the lower 2/3
Yeah.
and the upper will come
Probably in
post.
most cases, a headgear is going to be retractive, right? And you're saying not all cases, but I'm
No,
just
it can be an orthodontic and not be retractive, because it could
okay.
just be an anchorage device. But
Yeah.
most orthodontics are going to go, well, if that's what you're doing with it, let's use something that's inside the mouth that the patient's,
There's
going to be.
other ways. There's
Yeah.
probably
For many years, there's been other ways. Yeah.
So it's good to know we can't necessarily judge if a patient has a headgear. We can't necessarily say it's going to be retractive because it could be orthodontic and not orthopedic, but
Yeah.
probably in Most cases,
Yeah,
people would
most
lead to
cases.
something better, so we can assume. Because I have had patients who do have headgear or neck gear for their class 2 malocclusion, and as a myofunctional therapist, if we realize that orthodontist is doing a retractive technique, what do we do? Should we talk to the orthodontist? Do we? I always mention things from the perspective of the tongue. I'm like, can we bring things forward or widen to allow more tongue space, right? To speak from the tongue's perspective. What are your thoughts? How should a myofunctional therapist, should they talk to the orthodontist, approach that if they realize this child does have an airway issue, has sleep disordered breathing, and the child is in a retractive headgear?
Well, I think you do talk to them for sure. And I think use that opportunity to not educate, and it's not one's right and one is wrong, but we're in this together. And then I'd go to YouTube, I go to sources, and I say, here's some studies that support why we should bring it forward. Here's a case just like it I found on YouTube. There's so much that you can key in and it shows up. So I'd use some other case examples to assist in helping the other person see a different point of view and to get what you're trying to help them understand. And speaking from the tongue space, of course, that's a beautiful way to, because you both intersect there. And
Yeah.
that's what he's doing, she's doing. We need to help that be better. And then when we get into the sleep stuff and the tongue and the pharynx and all that stuff, it's even more. And, is there history to support that? There's snoring, there's something that you can add to the equation, or mom brought the video in that the orthodontist didn't see. So, by the way, here's what's happening when none of us are in that room at night, and just more factors like that to catch their attention and
Yeah.
hopefully have them see it a new way.
That's a great point, and you do talk about that in one of the other lectures you did with me. I think in part 1 or 2, you talk about using video and then educating our colleagues, educating the doctors and medical professionals with articles, research to back up what we're seeing and to describe, show them the data, show them what we're seeing. So when I do have a patient who is maybe in a retractive technique, or I can see expansions needed, but the orthodontist doesn't want to expand or isn't considering that, I send them my report and I let them know all of the historical signs and the symptoms I'm seeing. Parent reports, child snores, open mouth breathing, wakes up throughout the night, blah, blah, blah. And I say, there's characteristics of sleep disordered breathing. And can you please apply techniques that will help allow more space for the tongue, which can assist with better breathing and sleep quality, listing all those things. And
Right.
I think that helps them see the reason for the case and how we're working together. And it's beyond just like a tooth alignment or an orthodontic situation.
Yeah, well done. I mean, that's really well done by you. And it is difficult. You can lead them to water and can't make them drink
Yeah.
necessarily. It's really hard. And then you want that patient to get the best. And so you feel that commitment and that sense in your heart. So I want that too. And we've all done the
Yeah.
Hippocratic oath. It's not a Hippocratic oath, it's a Hippocratic oath. So we're going to
Mhm.
be hypocritic and not do the right
Right.
thing for the
And
patient.
I think also in that way, you're not offending the orthodontist,
Oh,
because you're not telling them they're doing anything wrong. You're just speaking from, as a myofunctional therapist, your
yeah.
own perspective of what you see. And you've just told them this patient has signs of sleep disordered breathing. Snoring, open mouth breathing is sleep disordered breathing.
Yes.
So you've just alerted them, uh-oh, now this is out there. You're kind of also responsible to help with this. What about extractions? Do you think extractions are ever necessary, or in most cases, should extractions be avoided?
Well, that's a lot of question there. And so we avoid extractions because I want to develop the arch early. So the earlier I can get the patient, the more chance I have. And then it always has to be back to the craniofacial type. I've been taught so much about that. Credit to others going before me. But the brachyface, we almost would never extract. There would have to be something where it's a surgical combined treatment plan that required it, or some pathologic condition. So just from a routine orthodontic standpoint, brachyfacial, we just don't extract because the faces are big and wide. The arches might be collapsed, but we can develop those. Mesofacial, then you're getting in the middle. And depending if you get them early, we're going to make room. We did research, Jay Wright and I at UCLA did his thesis on this, but back in the early 90s, late 80s, early 90s, there was a 5-year follow-up on patients. And at that point in my Marina Del Rey practice, it was 88% non-extraction in the upper arch, but it included adults. And within the adults, there were people that were getting multiple segment maxillary surgeries as part of the treatment, where we often would take a tooth out on each side to move the segments. And so it was 12% that had extraction in the upper, and it was only 6% in the lower arch then, of all ages. So I'm saying we've gotten better since then. And even then it was, let's say 5% in the lower arch, 10% in the upper arch. But that's 25 years ago when we did that research. And I can tell you, there's hardly ever we take teeth out, but I do. But I'll tell you another thing I do often in a class 2 crowded mesofacial dolical, I might take out the upper second molars if the upper thirds are developing really well, and then use that space to relocate the upper arch. So it's ideal, but all the premolars have been kept. Then we substitute the third molars. So that I did on one of our daughters, Katie, and face is beautiful, but it's that way it's not retractive. But I could have treated her with a premolar on each side, and I know I could have kept the same face. I could have kept the aesthetics, the airway, the different things, because the molar width would have been wide. I would have brought up the arch forward and kept the third molars, kept the second. I mean, I could have, it's how I would have managed the case. So I guess the answer is I lean real heavily toward not taking teeth out. We always treat the transverse first, which is the key to getting arch perimeter. When you get arch perimeter, you get room for teeth. And now if you manage that space really well, you can relocate the teeth, and it's not retraction. If we use all the appliances I showed that expand and make arch distance as part of the procedure, we're not bringing those teeth back to close the space. Everything is being brought into the space, but the arch is held forward in the face. It's beautiful how it comes out, and it's fast because the space is there to start with. So again, that's another way of making it non-extraction, but not because I want to champion and get on stage and say we never take teeth out. I think that there's a diagnostic untruth in saying that we never have to do that, because some of the faces need that. Some of our really complicated craniofacial cases need something out sometimes. And many times to do the surgery case, we have to decompensate the teeth so much that sometimes we have to remove a dental unit to get to the treatment goal. So we don't criticize our colleague unless we know the shoes they're walking in. But if it's a case that's clearly non-extraction, then it's a different story. I mentioned that in my Marina Del Rey practice, and some up here in Spokane too. We had so many patients that would fly in that had extraction treatments in youth or in adulthood, and then were unhappy, and after some time decide to go somewhere else. And you get on the web and you find people, and they come in from faraway places. So I learned from cases that were treated a different way, why not to do it, and how they looked 10, 20 years later. So it taught me a lot.
Yeah.
I learned from failures. Failures teaches us a lot.
Yeah. Yes. And it sounds like there aren't necessarily universal measurements for things like palate width. You're kind of saying it's more the craniofacial type that's going to help determine what.
Yeah, there is the width. Like I showed an example that it depends on the age, of course, but if you use that McNamara article, 37 millimeters, say 37, 38 across the molar. But then when we took our facial types of wide and narrow faces, then it's actually 2 millimeters less is the average and median, 2 millimeter more in a brachy. So that 37 isn't the number. It's 39 for brachy or more, and it's 35 or more for dolical. So we do measure that, and we use our coronal views. We measure the ratio, the 80% ratio, the width of upper to lower off the coronal view, off the cone beam. And we use that before off x-rays, but we always had trouble with it because you can't find the anatomy so well. On cone beam, it's there. It's true. I mean, we can find it, measure it, and then rely on it. So that helped us too. That helped us change. But I don't treat the numbers. We don't treat the face. If it, lean into the wider face, lead into the wider arch, and that helps the tongue space, the airway, and everything we could name.
What about if a child like a 4-year-old has undergone some sort of palatal expansion, but still has a really deep bite? So the transverse has been addressed. Would a deep bite warrant some sort of orthodontic treatment if there's other symptoms, like maybe the child's still snoring or behavioral issues? Or do you wait until the child's older because you've addressed the transverse? There's nothing else to do for like a 4-year-old. Because to me, I'm just thinking when there's a deep bite, because I have a case where I'm just thinking about this, that's my thought, that the lower jaw is trapped back. And this is obviously outside of my scope, but I'm just thinking, does the vertical need to be open? Does something need to be done to help release the lower jaw, bring the upper jaw forward when that bite is really deep?
Well, now I take that back to when they first started with, you said the transverse is managed. More often it's just the upper, something's been done. and the lower hasn't been corrected. So the lower is still compensated. And if you upright the lower wider, 3, 4, 6 millimeters wider, that adds to the amount the upper is going to change. But also, I mentioned that the second part always is the vertical that we're treating at the same time. So we're going to put turbos on deciduous teeth to rotate the mandible open more so that overbite is less, and then unlocks the mandible. So now it's neutral, but it's getting wider. And now the permanent teeth erupt. So that gets us a new height of the teeth, which rotates the mandible open. So the face height is more, the clearance in the front is more, but the mandible has been free all that time to be neutral and suspended and be able to develop forward. And the third part is the AP, because if they're over closed and they're angulated in, then we have to angulate those teeth out and improve that. So that's the nudging forward of the upper and lower during that same phase. I showed expanders with sweeps on the front, quad helix with sweeps on the front, Crozet, different appliances that can bring the incisors to a different place. And we use very early aligners too. So, I mean, that has come into view the last 10 years. So we might do the rigid expanders because you get more skeletal change, sutural change, development of the inferior nasal airway, and then go over to removables for another 6 months or a year to keep nudging it more. Because if we can develop that alveolus, then the teeth are wider perimeter, more room for tongue, but also bringing it forward and also bringing it vertically up. We want that facial height to come up.
Yeah. So it does sound like a deep bite is a sign still that lower jaw is trapped back.
Well, it could be over eruption of the teeth, but certainly if the bite's deep, we're looking at that and having some plan for that.
Yeah.
Yeah.
And you could do that at an early age, like 4 years old.
Easier at early age. Absolutely.
Yeah. Okay.
And even if it's let's say it's 5 to 7 year old and the lower teeth have erupted, now permanent teeth have come in. They're 6, 7, 8 years old and the lower teeth have over erupted because of the deep bite. It's very easy to intrude those teeth back down. The force has to be light. A lot of colleagues think it's a heavy force to get them to intrude because you've got this bone under there. It's the opposite. It's 25, 30 grams of force, real light, to make the teeth re-intrude. And then I showed the symphysis that it's wider as you go forward. So these teeth intrude real easily with light force. Then you bring them forward. You can use a mask or just segmental braces and wires, and we can angulate them forward easy. We can make a big change in how the overbite overjet is in a few months, but get those teeth back down where they belong. And everything else erupts to that. The case is made simple.
Can you talk about why it might be important to do transverse expansion even when there's no dental crossbite?
For sure. I mean, we're back to the skeletal measurements and proportions are first. I showed you the minor research, orthodontic colleague, where he basically identified the lower arch can be leaned in without posterior crossbite. The upper might appear to be wider than the lower, but it might be that the uppers are leaned in, compensated in, and then the lowers are leaned in even more because the top is the lid on the box. So the upper might not be in crossbite with lower posteriors, but the lower, when they're upright and brought to the axial inclination they should be and the width that they should be, then the upper has to be made to match that. And the good news is the upper can be expanded and the upper is the template. So we're going to expand that more, and the lower could be the limiting factor because the lower, if it's deciduous teeth, we're going to bring the alveolus out. It will develop slowly, and the upper is always going to be made wider, but it's going to be with the lower arch uprighted transversely. That's our guide clinically. When we do the cone beam, we're going to scroll through the coronal view, and we're going to go through, and we're going to see canine width, premolar, first molar width, deciduous molar width, permanent molar width, and we're going to look at that. But then down below, we're going to look at the morphology of the mandible, and we're going to see the teeth are way over the lingual ridges and where the anatomy is, and they need to be way out here. So we're going to look at the anatomy.
Okay. So with every expansion on the upper arch, does there usually have to be an expansion or an uprighting on the lower arch?
More often than not.
Because I don't see it that often, though.
You know, when you see a presentation, some of your guests, you know, they're saying, we got to expand that upper. Well, what about the lower? I mean, we've got a tongue down there, and we've got this whole airway, and two arches have to coordinate somehow, and it has to be in the face.
Sounds like it's more common that orthodontists will do like rapid palate expander or some expansion on the upper, but don't do anything on the lower. But we should be uprighting lower teeth to get more expansion on the upper. Is that correct?
Yeah, and there's a case I put in that I think it was a part 2 of our series together But I showed a case that had just done a consultation with me, a Zoom visit, but the lower had not been treated, and the orthodontist had just expanded the upper, but the airway conditions were unchanged, and the snoring unchanged, and all the restless and all the behavioral stuff was unchanged. And it was because that lower was what they were targeting, the upper to match the lower, which was way leaned in. It was just what we're talking about. And it was so simple. And then the other thing that's often missed, because the orthodontists aren't measuring this, and a lot of people that maybe don't rely on cephalometric measurements, but it's not for every case, but there's a lot of cases where we want to know the convexity. Where's that point A? And a lot of these cases that are narrow also need to come forward orthopedically. The upper needs to come forward orthopedically. Point A forward, 2, 3, 4 millimeters. That case in that Zoom call, when I showed the data, the upper was -4 convexity. It's supposed to be +2 or +3. So the whole upper arch needs to come forward, and then the lower to match. What does that do to the pharyngeal region? Really helps cross-sectional area, really helps for tongue. It helps for everything. And even if in our case had adenoids that were moderate and they were undecided about do we take them out or not, if we did all this in our first phase, the adenoid clearance is going to be better. The flow is going to be different. The resistance different. The turbulence different. So the adenoid might be less important if we're nasal breathing at that point.
Wow. So that's just really important to know. We can't generalize to all cases, but when we expand the upper, we're probably going to want to quote unquote expand the lower upright teeth. And probably in most cases, when expansion is warranted because the mouth is narrow, the palate's narrow, there's probably going to be some forward orthopedic growth that's needed also. So our kids, our patients that are just getting RPE might not be enough. Getting RP on the upper arch might not be enough.
Actually, one of the strongest allies for this would be 𝐃𝐈𝐒𝐂𝐋𝐀 had an article about the need for bidental expansion. Both arches need to be expanded. That's one of his key articles. He presented that information to the 𝐃𝐈𝐒𝐂𝐋𝐀 conference, and hugely important message that he brings. But making the point, hey, let's look beyond just the upper. That's a good start, but what about this lower? And he published that, and that's huge.
So for those orthodontists who are expanding and maybe thinking along the lines of Airway, we're like, yes, great, you're expanding the upper, but there's also more to it. So it's not, it doesn't end there.
I have an idea for colleagues out there. It's probably been 10 years ago already, but I went to PubMed and did a lit review of the last 20 years on articles that were orthodontic that had 𝐃𝐈𝐒𝐂𝐋𝐀. How do you say it?
𝐃𝐈𝐒𝐂𝐋𝐀, I say.
Christian
𝐃𝐈𝐒𝐂𝐋𝐶.
No, you're correct. But to give me, and it came up with 76 lit reviews that were in some orthodontic literature in some country. So I had all those to look at and say, oh my goodness, this guy's speaking to us and we're not listening. We need to be doing what he's telling us is needed for these patients, meaning the kids. And then I'll take it another level. On page 23 of the white paper, I think there's a reasonable challenge that the authors gave us, and we need to respond to it. I'm going to just quick read what it says. It says, what craniofacial variables contribute to the pathogenesis of OSA? And what airway function is affected by orthodontic treatments? And that could be favorable or unfavorable. But what are we doing that affects it? At what age? And does it progress from childhood to adulthood? Does it prevent OSA in adulthood if we enter early? And what are the endpoints for therapy? I think these are reasonable 6 questions that they're challenging us to give the data to. And so I've mentioned several times, let's verify, validate what we're doing. Let's share it, publish it. Let's put it in peer review journals, because that's where it has some strength and traction, not just somewhere. They're challenging us to say, give us the data and we'll listen. And there's more that probably should have been heard and different conclusions, but I'll take those challenges and let's respond.
Yeah, let's do it.
Let's do it. Like you said, let's do this.
Okay, I have a question about retention appliances. Do you feel that retention appliances are always or usually needed? And then my part 2 to that question is, what about like a Hawley retainer after a child's had expansion? Let's say we're talking about a 10-year-old and they wear the Hawley retainer. Does that actually prevent growth of the maxilla because it's holding it in the same place?
You're right. You're always right on top of it. I respect and appreciate that about you. But of course, the retainer's not growing. And so your question is kind of general. Do we always use a retainer? The younger the patient, the less we use any kind of retainer. Because when we look at the coronal section, the growth is foramen rotundum, but it grows down like this in the face. The face is getting longer and getting wider, and the retainer isn't. So we don't want the retainer holding the molar width, the shape of the arch, because we want that arch developing. So we might use it for 2-3 months upon removal of the expanders and so on. Mom doesn't want to see a space open up in the front usually. So if we've done something to limit that space or actually bring the space together, we'll sometimes put a wire behind the 2 center teeth just to keep that aesthetic placement. But we want the arch to develop quickly. So we want things out of there. So I would say on the younger patient, there's almost no retention. And on the mixed dentition, meaning the 7 to 11-year-old, there might be retention for 3 months, maybe up to 6. But almost always in retention, if we're in that phase where we had something in, now that something is out, and now we have some kind of retainer, the retainer is going to actually be something I can activate. So the retainer will have a little mini screw in the center. So every 2 weeks, we can add a turn and keep nudging it as they wear it. So it's not really a retainer. It's really an active plate. It's something that
like an expander, a removable expander.
It's removable. They put it in like a retainer. If it was a holly, there'd be a jack screw in the middle. It's cut right in half. There's a holly across the front, or a wire that you see. But the fact is that whole appliance is gradually widening. And we always trim it away so the tongue can reach the target, so the tongue can get up to the papilla. So that's removed. But we often have jack screws so we can activate them.
That was very enlightening. What about if a child is still a mouth breather, like open mouth breathing, their tongue's not resting in the correct position? Would perhaps a holly be okay in that case because it's preventing arch collapse?
Well, prevent, yeah. Or what about some kind of just trainer appliance, something that keeps the arch integrity, but it actually contributes to lip seal. So they have to seal around it, which now adds to the obligation to nasal breathe. So I'd want something to hold my arches, but something very thin in the front, very soft, that the lips can get over easy. And now they're nasal breathing, but they're controlling the width, the transverse in one appliance. And that's the ones I like are the ones that are the most thin, not anything big and bulky, but very thin. So you can get the lips competent over the appliance.
I agree, because even in myofunctional therapy, if some of these kids have these huge bulky appliances, it's like they can't even get their lips closed. It's almost the opposite of myofunctional therapy.
Yeah, and they're going to get discouraged. Mom will say they can't wear it, and that's probably true. So we need to give them something they can succeed with.
Well, that does get to my last 2 questions, and it's talking about myofunctional therapy. So how did you learn about myofunctional therapy? It sounds like you had an SLP in your office, but I want you to talk about that. And do you feel every orthodontic case needs myofunctional therapy?
Well, first part is we actually had 1 year where we had lectures from speech therapists, as they were called then, speech pathologists. So we had those in our training. So I credit that to helping our awareness. But for me, we weren't so much in tune with the frenum stuff, lingual frenum, of course. But it took us a while to really understand posterior ties and other things that we've learned the last 20 years. But the moment that I had a speech pathologist in the office, because I was referring patients, but when I did that and everybody was seeing her rather than hoping they would go to the appointment, they didn't a lot of times. So this way they were seeing her as part of coming into our office. That's when I learned the most, because then I could hear and see what she was teaching and doing and seeing the benefits of it. And it was just like, whoa, how could you not include this? It makes such a difference in my case success or what I can do for the patient by including that. So that was the aha moment for sure. And I credit Debbie Brady for all that she taught us and I witnessed. And going forward from there, I would say, no, not every patient needs myofunctional. I know that is different than what most of your colleagues would say, but there's a lot of times where I know I can overcome a habit with things I do, and then I can establish anterior contact by changing the teeth gradually. And then if there's a self-correction, which probably isn't really corrected, but at least the tongue placement's better. We've been giving him some things to do and establishing nasal breathing as part of it. If some of those things have now been corrected or improved, that patient, maybe I'm not going to urge too much, but I'm not saying that they don't have a need. I just think that's probably something where I'll accept that I've gotten the bite closed, I got the transverse, I have the lips together, I got nasal breathing. I'll always have them take a sip of water, and we'll video this. Take a sip of water, I'll look at the mentalis strain, I'll look at the temporalis movement or palpate it. I'll check lips, I'll see if they can swallow without the muscle movement, just different things. And usually they can't. So usually that means they really should have therapy. So the answer probably is 80% of the ones that come in with any kind of problem should see myo, at least
Well,
for.
it also sounds like you're saying too, those that maybe don't, you have addressed the nasal breathing piece,
Yes.
the tongue posture. So you are addressing some of the
Part of it.
myofunctional components, because we know we need to get the lips closed and nasal
Yeah.
breathing. I suspect you probably see some orthodontic relapse in cases where they did not obtain nasal breathing and have
Absolutely true.
mouth or
Yeah.
low tongue posture. So you are addressing that with some of those patients anyways, like you talked about in your lecture, nasal hygiene, teaching them the importance of lips closed and nose breathing.
Some of the little things we're doing for those patients, we might do something as simple as tell mom, you could just take a piece of paper, have the kid hold a piece of paper while they're doing their homework on the device, whatever they're doing, take a stir stick, a straw, just something. So the lips are definitely in contact and you have to nasal breathe. And then they're hearing this every visit from us and re-encouraging and that sort of thing. So I wouldn't call that we're doing the therapy you and your colleagues would do, but we're on the track. And if we have some that we can convince, go, let's get this finished right, they'll go. More importantly, though, is let's do that early. This isn't like therapy comes later if it didn't work. No, therapy is part of right up front what's important. And so if that's how we're seeing it, then that's emphasized.
It's part of the program. Yeah.
Right.
Part of the holistic treatment, right? Like
Yeah.
you said, we get all the team members involved because it's not just one thing. We're talking to ENT, allergy doctor, sleep doctor, orthodontist, myofunctional therapists. We all make up that team to help that child or that adult patient treat the issue and treat it for the long term. So
I agree. Yeah. So true.
so much great stuff from Dr. Grummons. Thank you so much. You've given so much of your time to help educate all of us. And again, I appreciate it so much. I appreciate all you do. And thank you so much for being here and being part of this.
Well, it's a great opportunity. I highly respect you and your people, your whole profession. So I thank you for that. And I admire your passion and your pursuit of new knowledge. And it's authentic. And I like how you want the truth and you want it complete. So
I really want people to share this episode, share this series with Dr. Grummons so people can spread this knowledge, share it to orthodontic colleagues, dental colleagues, so everybody can learn from all of your wonderful years of experience and training and all that you know and you've learned. Let's keep spreading this message and this information.
Yeah, so to share it. So
share it. Thank you all. Thank you. Thank you so much, Dr. Grummons.
My pleasure. Yeah. Bye-bye.
Thank you so much for joining this episode of Airway Answers. I'm hoping some of your Airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.